Hi, I'm Dr. Raj, and it's time again to talk about some questions from Beyond the Pearls. What should we talk about now? What about a concept that many USMLE Step 1 students have asked me? What is total oxygen content? Let's phrase it in a form of a question. I have a 42-year-old female comes in with severe smoke inhalation. Stop right there. Anytime you hear about smoke inhalation, what must come in your differential diagnosis? Oh, you got it. Carbon monoxide toxicity. She had a house fire, unfortunately. She's in the ER. She complains of severe headaches. She has cherry red discoloration of her skin and mucous membranes. Which of the following lab findings is likely present in this individual? Let's take a look at these choices. Number one, would it be a decreased arterial oxygen saturation? Would it be B, a decreased P-little-a-O2, partial pressure of arterial oxygen? Would it be C, increased AA gradient? How about D, checking a serum bicarbonate? Or E, is there going to be normal total oxygen content? Let's find out. So, when we talk about total oxygen content, especially in the artery, what makes it up? Well, number one, it's always going to be the oxygen bound to hemoglobin. And how many oxygen binding spots are there? That's right, there will be 4. And if I wanted to give it some terminology, what do I call the oxygen bound to hemoglobin? That's right, it's called the oxygen saturation, known as the O2 sat. Now, let's say I wanted to measure that value in the hospital, not on the board exams, because we always want to take our knowledge to the bedside. How do I get that value? Number one, the quickest way to do it would be a pulse ox. Just put in a simple pulse ox. But let's say your patient doesn't have a pulse. Let's say the patient's in atrial fibrillation. Let's say you can't get a good reading. What would be another way to measure the O2 sat? Oh, you got it. 3 letters. ABG, arterial blood gas. So that's going to be the first part of total oxygen content. What's going to be the second part? How about something known as the partial pressure of arterial oxygen? And it's written out like the big P, little a, O2. And what's another name for that? That's going to be called the dissolved oxygen. And if you want that dissolved oxygen, there's only one way in the entire planet to get that value. What procedure must you perform? Oh, that's right. An arterial blood gas once again. And if I were to ask you what things influence the partial pressure of arterial oxygen, there's always going to be 3. What are those 3 things? Number 1, atmospheric pressure. Number 2, FiO2. And what's going to be number 3? When you're hyper or hypoventilating. Those are the only 3 things that could influence the partial pressure of arterial oxygen. And now let's talk about the last part. Now what makes this last part unique is that you can't measure it. There's no exact value of it. It's a concept. And we call that the oxygen dissociation curve. You know that classic curve where we talk about shifting to the right, shifting to the left. And when we talk about that, if you shift the curve to the right, that means you want to give the oxygen off to the starving tissue that needs it. When you shift it to the left, that means the oxygen wants to stay bound to that hemoglobin. So what things can shift the curve to the right? Well, I'll tell you. How about a wonderful mnemonic? Let's think of the mnemonic TAP. You tap to the right. T stands for what? Temperature. What kind of temperature? Hyperthermia, fevers. Shift the curve to the right. What about A? Acidosis. So what would the pH be? Low. How about a patient who has sepsis and lactic acidosis? They definitely want oxygen. Shift the curve to the right. And P stands for phosphate, specifically 2,3-DPG. And what does this do? Well, anytime you're hypoxic, regardless of the etiology, you're going to get high levels of this 2,3-DPG. It's going to shift the curve to the right. But how about going the opposite way? Obviously, if the pH is going to be high, obviously if they're going to be hypothermic, obviously if they have low levels of 2,3-DPG, they'll shift it to the left. But you know what are some unique ways to go to the left? Let me just throw them out there. How about fetal hemoglobin? How about this one, myoglobin? Or how about, my friend, carbon monoxide? So what should we do? Let's go back to that question one more time. So what is going to be the right answer? It has to be A. Because when you look at those questions, number 1, how about E? Normal oxygen content? It doesn't make sense. Because when we talk about those 3 things, oxygen saturation, dissolved oxygen, and the dissociation curve, when one goes down, total oxygen content goes down. So it can't be E. D, serum bicarbonate, that makes no sense. Did we mention anything about bicarbonate? Did we mention anything about being acidemic or alkalemic? No. How about C, the AA gradient? Well, what does that mean? Is there any problems with gases going from the alveoli through the interstitium and into the capillary when you have carbon monoxide toxicity? No, so that's not going to be the right answer. What about the P-AO2, choice B? That can't be the right answer. You know why? What are the only three things that affect the partial pressure of arterial oxygen? Atmospheric pressure, FiO2, and hyper and hypoventilating. We said that. So by default, the only answer could be A. You know why? Does carbon monoxide love hemoglobin? Oh my God, it totally loves it. And it steals one of the binding spots for oxygen. So what happens to the O2 saturation? It decreases. So the answer here is going to be what? A. Outstanding. You know what? I'm in a generous mood. Let's do one more question because now that we're in a good mood. So how about this 60-year-old male? Just undergoes a bronchoscopy. One of my favorite things to do in the whole world being a pulmonologist. Taking the scope in there, and you know what I did? I took some biopsies of the RLL. You know what that stands for? Right lower lobe of the lung. You know, but after the procedure, he's tachypnic, he's breathing fast. He's looking cyanotic. What did I do? His oxygen saturations are 87%. But you know what? Key teaching point. It does not, and let me say it one more time, does not improve with the addition of oxygen. Ooh. Breath sounds are equal bilaterally. The chest is rising. Which of the following interventions is most likely to improve his condition? So let's look at these answers together. How about, let's go from the bottom up. What about E? Putting bilateral chest tubes. Wow, that seems pretty invasive. Not really a good test-taking answer. And what are we doing? Why are we putting two chest tubes in? I only biopsied him where? The right lower lobe. And I know what you're thinking. Does he have a what? Pneumothorax. But if you had a pneumothorax and I gave you oxygen, would you respond? Yes. This patient didn't respond. So I think E, being a little too aggressive, the fact that it should respond to oxygen is not going to be the right answer. How about D, intubate? You know, when I'm with my pulmonary critical care fellows, I think the answer is always intubate with them, but I do love them dearly. But the answer is not going to be intubate because of the fact that, for what? And why is this patient not responding to oxygen? C, getting a chest x-ray and ABG. In this acute situation, are you going to be like, you know what, buddy? I know you're tachypnic. I know your oxygen saturation is 87%. Just hold on. Let me get that x-ray. Let me get that ABG. So the answer is, you know, I'm not saying we're not going to get it, just not the next thing to do in this patient. Well, how about A, hyperbaric oxygen? You know, anytime I think about hyperbaric oxygen, it's usually when we think about those diving diseases that they call Kazan's disease, the bends. And do we commonly have a hyperbaric chamber right next to our 7-Eleven down the street? The answer is no. So it's not a practical thing to do, and why would we do it anyways? You know, why would someone after a bronchoscopy need a hyperbaric chamber? So by default, I think I told you what the answer is. It's got to be methylene blue? Where did that come from? What do we use methylene blue for? Oh, you know what I'm talking about. Methemoglobinemia. So I don't know what you're thinking. Why does this patient have methemoglobinemia? Because when you do a bronchoscopy, when you put that scope in anyone's trachea going through the cords, oh boy, you know what? You're going to be coughing and coughing and coughing. Does anyone out there want to take a guess? What does Dr. Raj use to kind of numb up those cords a little bit? What do we use? Oh, lidocaine. And when we talk about lidocaine, it is a drug that loves to induce methemoglobinemia. And let's talk about what methemoglobinemia is. Well, two things can cause it. Number one, genetics. Number two, drugs. And remember hemoglobin? We talked about the question before. Let me just take it up a notch. Hemoglobin loves to have a little iron moiety connected to hemoglobin, a little porphyrin ring per se. And that likes to be in the what oxidized state? Oh, I heard it right. That's going to be in the ferrous, the Fe+2. But things can change it to the ferric state, which is Fe+3. And you know what happens when you change that iron to the Fe+3? All of a sudden, that hemoglobin starts acting like carbon monoxide toxicity, meaning that oxygen can't be given to the starving tissue. It just stays bind to that oxygen, to that hemoglobin, shifting the curve all the way to the left. And that's not good. So when we talk about what can do it, definitely drugs, think about nitrates, things like lidocaine. How do you diagnose it? You need to have a ABG with a co-oximeter to look for that methemoglobin. How do we treat it? Think about the antidote, which is always going to be methylene blue. So when you have a patient that doesn't respond to oxygen, you put a pulse ox that's 87%. You know why it was 87? Not because the patient was truly hypoxic, is because there's going to be less binding spots on that hemoglobin because of that induced methemoglobinemia. So before we say goodbye, let me just say this one more thing about the question, that if you give methylene blue, you always want to keep an eye on my good friend, the hemoglobin. You always want to see what's going on because people who have methemoglobinemia can undergo hemolysis. And what hemolysis is associated with giving methylene blue? Does anyone know that out there? Oh, and the answer is G6PD deficiency. So always get that peripheral smear, look for those bite cells, and think about that extra little pearl I just gave you. I hope you love these two cases. These are things that if you enjoyed them, you want more of them, check out my book, Medicine Morning Report, Beyond the Pearls. You can get that at Amazon. You can get that at the Elsevier website. I'm Dr. Raj, educating you today for a better outcome tomorrow.